All right, perfect. We are now being live streamed as well. So Dr. Dempsey, you should be able to go to our page and reshare at your convenience.
Looking for it.
Awesome. All right. Now that we are getting started, all of our attendees, or majority of our attendees, are here. We have both the experts. Let me go ahead and introduce them. So I'll start first with, on my bottom screen, we have Dr. Neil Nathan, who is the author of Toxic: Heal Your Body from Mold Toxicity, Lyme Disease, Multiple Chemical Sensitivities, and Chronic Environmental Illness. He has been in practice for over 50 years, is a board certified family medicine and pain management individual, and is a founding diplomat of the American Board of Integrative Holistic Medicine, as well as the International Society for Environmentally Acquired Illness. So he clearly has a lot of expertise across all of the topics we'll be discussing tonight, and we're thankful for his participation. In addition, on my top screen, I see Dr. Tanya Dempsey, who is the founder of the AIM Center for Personalized Medicine in Purchase, New York. She is a board certified in internal medicine and integrative holistic medicine. Dr. Dempsey is an expert in mast cell activation system syndrome, autoimmunity, ME and CFS, mold illness, and vector-borne infections. She has also co-authored numerous articles in the medical literature, including one from 2021 titled "Mast Cell Activation May Explain Many Cases of Chemical Intolerance." Dr. Dempsey is a sought-after physician for her international knowledge of chronic immune deregulation. So thank you both for being with us this evening. We're really going to work through outlining the symptoms of Lyme disease and mold toxicity, as well as talking about what individuals can do to get tested for it, both individually as well as in their homes, and then outline some general remediation concepts, but nothing too specific, just given the background of these two individuals is focused on practicing. So I will go ahead and jump into our outline here, which is symptoms. We'll start there. Patients are already experiencing a multitude of symptoms from tick-borne disease. So I'll start first with Dr. Nathan. What happens to these symptoms that patients are already experiencing when they're exposed to mold or mycotoxins?
They get worse. The inflammation triggered by Lyme and co-infections is triggered by what we know to be cytokines, which are kind of an inflammatory molecule that circulates in the body, which the body has trouble turning off. It turns out that although mold is not a bacterial illness, but a toxin, toxins can do the same thing. So you get very, very similar symptoms from mold that you can with Lyme and with Bartonella and some of the other co-infections. There are a few symptoms that are somewhat unique to mold and somewhat unique to things like Lyme and Bartonella. So experienced clinicians can begin the process of teasing them apart, but we often have to go to lab testing to really get clear about it, because it's very, very common for people to come in with all of the complaints that Lyme patients have and discover that a lot of it's mold, and vice versa. So I'll start there, and maybe Tanya wants to chip in.
Yeah. Do you want me to build on that? Can I go ahead?
Please do, Dr. Dempsey. Please do.
I thought we would share, Tanya, so that we kind of ping pong back and forth here a little bit.
Yeah, I love it. We'll keep it interactive.
Yeah.
Yeah. Well, I mean, I completely agree with everything you've said, and I'll add in that the one cell that I'm a little obsessed with, which is the mast cell. And I'll say that, you know, a lot of it is that the mast cell, which is the part of the immune system that's your first line of defense, and it's really what's protecting you from the environment or helping you interact with the environment. So if you're exposed to various infections, mast cells can get activated. If you're exposed to mold or other toxins, they get activated. And so it's almost a cumulative effect. It's all these things together really is just what is going to make the situation worse.
Right, and I will completely agree with that. Audience should not be surprised if Tanya and I agree on a lot of things, since we have taught together in the past.
Yeah.
Yeah.
Awesome. Well, thank you both for outlining the initial symptoms that you may see with Lyme disease and mold activation. I'm curious, Dr. Nathan, for you to dig a little bit deeper into that concept of teasing between the two. And Dr. Dempsey, obviously, building upon any of his responses as well. But that's something that's very interesting to me, and I'm sure our patient body would agree, is if you have Lyme, how do you know that mold may be increasing your symptoms? And how do you know which are directly as a result of that mold or directly a result as your tick-borne illness?
That's a lot of questions, and I'll try to
Yes.
answer them in some kind of a organized way. So first of all, let's talk about some symptoms that are kind of unique to mold. So electrical sensations, electrical pains, ice pick pains are somewhat unique to mold. You can see it in other conditions, but if someone describes that, that's a bit more likely to be mold. On the other hand, Bartonella, for example, has pain on the bottom of the feet, a plantar fasciitis-like condition, which I don't see in mold. I'm going to flip back and forth between this. Neurological or cranial nerve issues are common in Lyme. I don't see that in mold. So we can begin to have a few symptoms that point me in a specific direction. Some patients complain of a vibrational feeling in their body, often in the spine, could be in any part of the body, and it isn't visible, but it's really quite upsetting and annoying. And typically I see that in both mold and Bartonella, not so much in some of the other conditions. So using these symptoms is a little bit of a way to tease apart some of what a patient is describing. To then address the question of how, if a patient knows they have Lyme disease, but they're not responding well to the treatment, it could be several things. One, the Lyme is actually cured or in remission, and it's mold that are actually producing the symptoms because they're so similar. And I do see that quite commonly. Second, if someone is just so inflamed and they're not making any progress, then mold should be looked for. Honestly, the symptoms are so similar, and I see mold and Lyme in so many patients. I would suggest that any patient with Lyme get checked for mold to be sure that we're not missing that early on. And both mold and Lyme and Bartonella trigger mast cell activation, which adds another layer of inflammation to all of this. So I'll pass the baton.
I couldn't agree more. Are you surprised?
No.
No. Yeah, I mean, all the above. I mean, I think that, I'm starting to really test everybody who I think has tick-borne, vector-borne infection for mold, and actually vice versa now. Because it is so common to sort of see that overlap. The patients who come to me, let's say, and they've seen other practitioners and they're not getting better, that's a real red flag. Let's say they're not getting better from Lyme treatment. It's a red flag that they have a co-infection that hasn't been found. They have mold exposure or toxin exposure. So, you have to sort of listen to the patient, put the information together. But more and more, I think we have to cast a wider net when we test these patients, because it's really starting to become more obvious that there are so many things that these patients are dealing with.
So, Dr. Dempsey, I will start with you on this one, just so you're not
Not
fully.
impressed?
Yeah, Dr. Nathan, could you dig a little bit deeper into the concept of testing? What type of tests do you use, and how are you finding results and conveying them to patients?
So is the question about mold testing?
Correct.
Specifically? So I primarily use mycotoxin testing. I don't know if you want the lab, but I use real-time lab primarily these days. And I think that there are some challenges to the test that, we think about whether patients are actually are detoxing properly, and we can actually isolate the mycotoxin in the urine. I'm always a little surprised when I get a completely negative result, when I have a high index of suspicion. So I might do something called a provocative test to sort of help them detox. So glutathione is something we might use to help them basically get the mycotoxins into the urine so that you can collect it and find it there. So that's the primary test. There are other tests that people are using, antibody testing, which I can't wrap my head around yet in terms of how that really translates to their illness. I think the mycotoxins are the big problem for the most part, although mold itself without the mycotoxins can carry its own set of issues. It definitely can set off mast cells alone. Mycotoxins can, and so can mold, and in various ways. And there are other ways that mast cells are involved in trying to get rid of mold. We have the added issue. We have mold outside our environment. We have mold inside our environment, inside our body, potentially. These patients sometimes have overgrowth of mold. They sometimes breathe in the mold and they get mold in their lungs. So sometimes there are other tests that have to be done to look at that. We might look at a stool test. We might look at a test of sputum from their lungs. There may be some blood tests that can give us some information about how bad the situation is. So that's primarily what I do. We can see what else Dr. Nathan thinks.
Once again, I agree. Of the labs that are out there, I also think that real-time does the best job currently available, not only for comprehensively figuring out which toxins are present, but for follow-up testing, I find their testing more consistent than some of the other labs that are on the market. The one test that real-time does that isn't quite as accurate of the 5 things that they run is ochratoxin. And I do find that the Great Plains lab does a better job on that, so that I'll often ask patients to get tested by both real-time and Great Plains. What I'm looking for from Great Plains is primarily ochratoxin, which is really quite common. And from real-time, I'm going to get a more accurate level of everything else that's in the system. The two together, fairly comprehensive. There are a couple of labs available. I don't find them quite as accurate. There are what are called marker tests, which some people call the Shoemaker labs. These measure inflammation, but not specifically. So these are like an alphabet soup of names like TGF beta 1 and C4A and MMP9 and VIP and VEGF, all of which can point us in the direction of an inflammatory process, but doesn't really tell us, is it mold or is it Lyme? Because both will produce elevations in many of those laboratory testing. There's also a test you can take online called the visual contrast test, which will give you another screening test. Once again, it'll be positive for mold and Lyme and mercury toxicity. So those tests, from my perspective, aren't as specific. Since treatment can run to a whole lot of dollars from a diagnostic point of view, for me, I go right to urine mycotoxin testing as my first choice. That tells me very clearly what I'm looking at. And I'll expand a little bit on what Tanya began to talk about, detoxification. Our testing of urine mycotoxins measures not only what's in the body, but that body's ability to detoxify. And perversely, mold toxin interferes with the body's ability to detoxify. So you could have someone with a boatload of mold toxin in them and they can't excrete it into the urine adequately. So sometimes you'll find someone with only slightly elevated or even normal testing, and you go, gosh, they have a history of it. They have mold in their home. They have every symptom. I'm pretty sure they have it. So these are patients that I would treat empirically in the same way that I treat Lyme patients empirically, because Lyme is still a clinical diagnosis primarily, so that we find that after treating people for mold, if I retest their urine in 4 months, 6 months, now it's loaded. And the vast majority of people where I think they have it, they really do.
So, unless you had anything you wish to expand upon, Dr. Dempsey?
Oh, yeah, no, I totally.
Okay, I think a great way to build on that is you've talked about identifying individuals. However, how do you identify exposure? And I think that's something that, I've heard Dr. Dempsey and both Dr. Nathan talk about mold in your home, but what's the process of identifying that as well as any potential external factors that are affecting people? And Dr. Dempsey, we'll bring it back to you. That'll be 2 for Dr. Nathan, 2 for Dr. Dempsey.
Okay, oh, we're keeping score. Good.
I appreciate fairness.
Me too.
You're both bringing so much to the table. I want to try to keep it spread around as much as possible. So, Dr. Dempsey, I'm curious to hear your thoughts.
So, yeah, so first off, we're treating the patient, right? So we're identifying these issues. We're identifying exposures, and you really have to take a very, very good history from the patients in terms of all their exposures, right? We have to think about, I ask questions about their home. I might, has there been water intrusion? Has there been any kind of evidence of water anywhere? Do you see any mold? Usually they don't see mold. When was the last time you had your HVAC systems cleaned? Did you ever have your HVAC system cleaned? How old is the home? There are many, 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 many more questions that I ask. I might ask about their work. Sometimes it's very clear that it's the job because they'll say right away, I smell something the minute I walk into the office. But sometimes it's not so obvious. So we really have to dig, because to figure out where the exposure is and then to fix that exposure or to take care of it, right, can cost, a lot of money. It's very expensive endeavor. So you really need to nail it down. If it's the home, that's more likely they spend the most time there. Then, we, talk about getting a mold inspector to come into the home. Many mold inspectors will look first to see if there are any obvious areas, and then hone in on the areas that they think need to be tested. Now, a lot of mold testers have different techniques and technologies that they use to measure mold. Some will use air sampling, some will use ERMI testing and swabs, and there are various methodologies for this. One of the things is that there are very few mold inspectors that do, but there are a few in this country that do, is test mycotoxins. Because I think that if you can isolate the mycotoxins in the home and you can compare the mycotoxins to the patient, it can be very, very helpful to really sort of nail down the issue and the exposure. So those are some things that I talk to patients about. I help sort of guide them, when they're looking for inspectors and when they've had the inspection. I'll sometimes review I often actually review the report. And because patients have a lot of questions about, well, what is it going to take to get me better? So I have mycotoxin exposure, I have mold exposure, I have Lyme, I'm trying to get better. What is it going to take to get better? We can detox them and give them binders or antifungals sometimes, or whatever we're doing. But if they're continuing to be exposed, they're not going to get better. And the question is, what do they need to do in their living environment to get better? And sometimes that's not the easiest thing to figure out. Do they have to gut the whole house? Can they change the HVAC system? Can they, get rid of, one little area in their bathroom? It's a very, very complex process to figure it out. But when it is figured out, and when patients have eliminated their exposure, their ability to heal, to finally heal fully, is realized.
Okay, so I'll expand on that a little bit. So first of all, let me lay out that if you're going to treat mold, there are 3 main things that you have to look at for everyone. First, as Dr. Dempsey is talking about, you've got to look at their living environment. And I want to put this as categorically as I can. You cannot get well living in a moldy environment. I'll say it again. You cannot get well living in a moldy environment. Now, this brings up huge issues for most families. So, well, do I have to move? Do I have to sell my home? I don't have any family nearby to live with. How do I get out of my home? It would be expensive to live in a hotel. Do I have the money to afford a remediation, which can run to $100,000 or more dollars sometimes? So huge issue. And often we see a ton of denial come into play right at this point, where people will go, oh, I don't smell it, I don't see it. There can't be mold in my environment. And our first job is to convince patients to take this seriously, which is you're not going to be able to get well living in a moldy environment. Now, sometimes people will be, dig their heels in, and you go, okay, fine, I'll treat you. Let's see how you do. Now, you can treat someone and they'll get a little bit better if they're living in a moldy environment, but they just can't get well. So if I'm working with patients and they're not improving, or they're doing their follow-up urine mold test and it's worse, then I can look at them and go, come on, we have a real problem here. We can't just put our head in the sand and ignore it. We really have to deal with that. So from a testing procedure, testing the home, work, car, sometimes we go every Sunday to my mom's house for dinner, and I know I smell mold there. It's a very old building, or a friend's house. We have to do detective work, as Dr. Dempsey says, to figure out where is it coming from? Where am I getting exposed? And you know what? They might live in a perfectly clean place. It might not be where they're living now. It could be where they were living 5 years ago when they got involved. So you can be exposed 5, 10, 20 years ago and still have mold growing in you from that exposure, usually in the sinus and gut areas. So that for some people, I said there were 3 components to treatment. So the first, which I've been going on about, is evaluating the environment for safety. Second, using binders to pull the mold out of the body. And here's where the urine mycotoxin tests are very useful. We actually know that certain binders work better for certain mycotoxins. So looking at that report, I have a blueprint of what I need to do to treat them with. And I'll do that using every binder that I need to pull those toxins out of that person's body. And lastly, if the patient's not getting better, they probably colonize with mold in their sinus and gut areas, occasionally or rarely the lung. And then I have to use antifungal nasal sprays and antifungal orally to get it out of the body. But I want to emphasize my take-home message always is this is treatable.
I think a perfect follow-up question comes from one of our audience members, Alexis. You just mentioned how mold exposure, Lyme and Bartonella can all occur simultaneously, and one of the first steps is to get out of a moldy environment. Well, she asks the question is, if that's possible, what's next? What do you treat first, or is it done simultaneously?
Well,
and Dr. Nathan will come back to you.
Okay, well, we might have different answers. Tanya and I both taught with Rich Horowitz, who I consider to be our country's foremost Lyme specialist, on the cutting edge pioneering how Lyme and all of the co-infections should be treated. We've all spent a whole weekend together teaching physicians how to do this. And I know that Dr. Horowitz and I have a different answer, so I'll give you the different answer. And I'll give you my reason for it. From my perspective, if you have mold and Lyme, you treat the mold first. I'll also tell you that from Dr. Horowitz's perspective, you treat the Lyme first. And I totally value his friendship and expertise. But I'll give you my rationale.
The third way. So I'll let you finish and then I'll tell you my way.
Okay. All right. Now, my practice has always been primarily very sensitive patients, people who have become unusually reactive, and that's who's been referred to me for the last 20 years. So what I'm going to tell you is biased by that perspective. So for those patients, it's often too hard on their bodies to take the antibiotics you need to treat the Lyme effectively. It's easier to treat the mold first. It's less invasive. It's not as harsh on the body. And I don't know to what extent mold or Lyme or Bartonella or Babesia are playing a role. So for me, if I can take the mold layer off, there may not be much of a layer underneath it. I've had a lot of patients treated for years by Lyme specialists who haven't looked at mold. Now, without realizing it, they had completely treated the Lyme and Babesia and Bart and Ehrlichia. But what they didn't realize is they still had mold. So for a lot of those patients, if I treat the mold, I'll take that layer off, and by gosh and by golly, they're well. They don't have another layer underneath it. So for those reasons, I always approach mold first. But I want to toss a couple of thoughts in, and I'm going to put mast cell activation in here. Again, dealing with sensitive patients before I treat mold and before I treat Lyme, I often have to treat their limbic system, their vagal nerve system, and mast cell activation, or they're not going anywhere. That those three systems are involved in protecting the body, and they become hyper protective, hyper vigilant, and they limit healing from any perspective if we don't address them first. So my order of treatment is limbic and vagal and mast cell first, then mold, then Lyme.
You stole the words out of my mouth.
Oh dear, I'm
No,
sorry.
no, it's good. It's all good. Because really that's exactly my approach. I wouldn't even go near the mold or the Lyme in a very sensitive patient. I'm going to, fix sort of their immune response to their environment first. I mean, the reality is that a lot of people are exposed to toxins and mold in the air, but not everyone is sick, right? And I think that comes back to like, why are people more the patients we see more likely to be sick than their family members or their friends? And it has to do with their mast cells, their limbic system, and their vagal system, right? So, and their vagal nerve. So those things have been primed genetically, epigenetically. And so if we can sort of deprime them, if we can help to reset them, then their interaction with the environment changes, their tolerance of the environment changes. So this is some of the work that we looked at with chemical intolerance and mast cell activation syndrome. Mast cell activation syndrome probably explains chemical intolerance. The worse the mast cells are, if I'm just looking at mast cells, the worse the chemical intolerance could be in a subset of patients. And you stabilize their mast cells and you help their limbic system and everything else. And then their chemical intolerance gets better. It's not that chemicals are good for them, but they don't respond the same way. So that's how I think about it. And sometimes just doing that, it saves me from having to treat their mold or their vector-borne infections. It's really remarkable when it happens.
Yeah, and again, I completely agree. And I think what Tanya is referring to is, she called it priming, and that's really what it is. We all grow up with different stressors throughout our life. Some of us have had semi-idyllic childhoods, and some of us have horrific childhoods. The more stressors that someone has to go with, the more that vagal system and that limbic system get more and more reactive. So even as a child, bad things happen. And the child's way of dealing with that is, I have to become more aware of my environment and the stimuli I'm getting exposed to, and I've got to protect myself. So, and then we become more and more and more protective. It's a lifetime of doing that. That may culminate in the teenage years if severe enough. It may get into the teens, might not happen until you're in your 60s or 70s, but it's a lifetime of accumulated stress that predisposes this system that weakens the immune system, if you will, to react. And in this context, Lyme weakens the immune system, predisposing to mold, and mold weakens the immune system, predisposing to Lyme.
So I think a really good follow-up question to this is from one of our audience members, Nicole. I have an expectation of what the answer is, but I'm curious to hear what both of your thoughts are. What is the time frame for mold treatment? And Dr. Dempsey, I'll start with you.
Well, again, right, there's so many variables. So the patient has to be out of the moldy environment, right? Dr. Nathan said that, right? They cannot get better if they continue to be exposed to mold. So that's a part of the treatment. And that may take time, right? For everybody, you know, who they have to figure out where their living environment is going to be, if they're remediating or where they're, you know, where they're going, right? So that's part of it. Then there's the actual treating the if you're treating the mold with the mycotoxins with binders, you know, you might have to use different binders at different times, depending on the mycotoxins. And then of course, there's all these other things that they may be dealing with as well. So I hate to put a time frame. I mean, I'll be curious to see what Dr. Nathan says, but I usually, you know, set expectations for patients that this is, you know, this is not a race. We can't, you know, I want to get them better as quickly as possible, right? But it could take months or years potentially, depending. But sometimes it, you know, it can be faster. And I like Dr. Nathan said, you know, I'm very optimistic. This can be treated. People can get better. But I think you have to have, there's a range of how patients respond, especially if they also have mast cell activation syndrome, especially if they also have infections. So it's varied.
Yeah, as Tanya said, I'm going to give you an answer more concrete,
Okay.
but it does depend. If someone has only recently been exposed, then it's possible that simply remediation or getting out of that environment, coupled with binders, and they might be able to get well in 3 to 6 months. I rarely see that anymore because I have a referral practice where other physicians' most complicated cases get dumped on my doorstep, if you will. So the people I see have become, first of all, they've been sick for years. It is not brief exposure. It's a long-term exposure. And they also have Lyme, and they also have, and we're off to the races. So in my patient population, I will tell virtually everyone that it takes at least a year to get the mold out of your body. And you did not hear the words "at least," because they didn't. People will come back to me and say, "You told me I'd get well in a year." I use the same language every time with every patient. So I said "at least." So some people for mold alone take 2 or 3, occasionally 4 or 5 years to pull the mold out. It can be a long time. Often that's largely related to not being able to get out of a moldy environment or not finding mold where it is in their current living environment. And it takes time sometimes to get that figured out. And if you have mold and Lyme, I will typically tell my Lyme patients it's going to take a year or 2 at least to get well. And so that becomes additive. So this is not a quick fix, but the vast majority of people I've treated over the years have gotten well. So I come to the table with optimism, I come to the table with hope, but I also come to the table with reality testing, which is if I were to tell you you'll be well in 3 months, all you'll find out in 3 months is that I'm a liar. And I would prefer you not find that out at that early in our relationship.
Awesome. Yeah, I think that what you just stated, Dr. Nathan, about the time frame is something that even just tick-borne disease patients can expect and have heard time and time again. So that's why I said I anticipated your answers, but definitely I think your specificity with both of them, Dr. Dempsey and Dr. Nathan, helps any patient who's curious and learning more. So in that same vein, we have received a lot of questions from patients. So I will follow up with one from Nilufar. They mentioned that they've had both Lyme co-infections and mold, and that their doctors told them that antibiotics would take care of all of the above. Is that an experience that either of you, that is the reaction I expected as well. Have either of you seen or heard that prior?
We've heard it.
Yes.
Definitely correct. Yeah, no, unfortunately. Yeah.
Unfortunately, Lyme has become better known even in conventional medicine, although it's still not have fully made its way into consciousness. And mold is 10 or 15 years behind. It's, for me, very straightforward. Antibiotics will not kill mold or affect it in any way, shape, manner, or form, other than make candida and mold in the gut worse. So it just makes no sense to hear a statement like that. Mold has to be treated differently than Lyme. They're very different illnesses, different causes, completely different microorganisms cause them. They're not in the same family. So you have to view them as completely different entities and come at them from very different perspectives.
And I'll say that the same is true for Lyme and co-infections, right? There's this term, people use Lyme as an umbrella term. And they come in and they say, I have Lyme and I'm being treated and I'm not getting better. They said that, this treatment protocol would help me. But what they really have is Bartonella, which is treated differently than Lyme. It's treated, differently than Babesia. So I think it's important just in general that we all physicians, practitioners who are treating patients like this start to really hone in on the actual problem. If there's mold, it's mold. If they have candida, it's candida, right? If it's Lyme, if it's Bartonella, Babesia, we have to be more specific because the treatments are so different. This is one of my pet peeves. Unfortunately, it's
Yeah.
Yeah, I know that antibiotics is always a common question that even as Project Lyme, not being practitioners, being a nonprofit, that we receive all the time. So we did put together a very in-depth antibiotic-specific resource for Lyme, but that doesn't apply, as you just mentioned, to every tick-borne disease, any of these other infections that people might run into, mold, mycotoxins. So it's always very important, as both of you have made clear, to work with a professional who is knowledgeable of mold and mycotoxins that you might be exposed to, in addition to any Lyme specialist, because there seems to be a lack of overlap in a lot of key areas that would lead to the underlying question of how do I get well? So
one last thing, if I can add, my other pet peeve, we often refer to Lyme and co-infections as tick-borne infections, but they really should be called vector-borne infections because there's so many different vectors, insects of different kinds, spiders, fleas, lice, that can transmit, serious infections like Bartonella, Babesia, et cetera. So I just want to petition for the change to vector-borne infections.
Yeah, I would say every year we've slowly been kind of flicking our lens back from being very Lyme only focused to now it's been tick-borne infections. And I would definitely say give it another year or so, and there's just going to be even more reasoning for that further flick back out to the vector-borne concept, because that's not the first time I've heard that from an expert in the field. So I am going to personally look to incorporate that more into my day-to-day conversation, and I hope that all of our attendees get the message there as well. But to look back to our open Q&As, we have a lot here. Some people are saying thank you for the insight on that, but some people have also asked more specifics that I don't think we need to get into, but can you dig into the concept of specific herbs that may be utilized for mold treatment? Mainly because people have talked about binders and have mentioned things like cholera, probiotics, etc. Can you both dig into that concept a little bit? As their usability of herbs for treating mold and mycotoxins.
The word herb may not. The word herb might not be doing it the world justice here.
Sure.
So, for example, there are a wide variety of approaches. I work very closely with a naturopathic physician named Jill Krista, who wrote a wonderful book called Break the Mold. And Jill's approach is primarily herbal, but she, as a naturopath, is aware that some people require pharmaceutical agents to get the mold out of the body if they've colonized. So I would say, and I'm going to say this for Lyme as well, just using herbs as the sole approach, my experience, rarely works. And I have worked with a lot of herbal approaches. I wrote the foreword to Stephen Buhner's book, Healing Lyme. I'm very aware of Buhner's herbs and Lee Cowden's herbs, and I use them. I find them helpful. They're excellent adjuncts. But rarely, in my experience, is someone with Lyme going to get well unless they use antibiotics also. Similarly, in the mold world, we have, I'll call them botanicals or herbal products, which can be binders like chlorella, charcoal, clay, propylmanin, Saccharomyces boulardii. These are excellent binders depending on which toxin I'm trying to pull out of the body. But once we get into pulling, killing, using an antifungal, again, we can use Dr. Christa's approach. I have found that we often need to use pharmaceuticals like nystatin and diflucan for candida, like amphotericin B and itraconazole for oral, for GI-based fungus and candida. So again, this is complicated. I want to say, please don't treat yourself. This is really a pretty complicated area. You really need to work with someone who has some experience and knows what they're doing. If you treat the wrong way in the wrong order, you're really likely to make somebody worse. And that's not rare. It happens all the time. If anyone listening wants a list of practitioners that I've trained that can treat mold at least, and they also, almost everyone there treats Lyme, go to my website, which is just neilnathanmd.com, and look under medical practitioners. Okay, I'm not included in that list, by the way. I retired after 50 years, about a year and a half ago. I do consult a great deal with other physicians on helping them with their patients. So just letting you know, there is a place you can find people that we've trained to get help that you need.
Awesome. I think that was a really well-rounded response, Dr. Nathan. I will not be posing, given that response, any more of the questions that have come in from our audience that are very specific to the use of individualized herbs, botanicals, however you may refer to them, because there have been a couple. And I would just reinforce what Dr. Nathan has said, is that this is very much an educational program. There's no specific and direct treatment recommendations being made, only discussing experience in the field. And as always, we would refer you to check out a specialist. Dr. Nathan, as he mentioned, has a list. Project Lyme also has a great database for tick-borne disease specialists. And all of these links I will be sharing in a follow-up email with this video tomorrow. So anybody who's registered or is attending will receive a direct email from me with these links if you would like to dig deeper into finding your own specialist.
Yeah, let me expand on that for a second.
Sure.
People have asked me for years for the Nathan protocol. And what I have said for years is I don't have one and I'm not going to give you one, because every single patient that I work with has unique genetics and biochemistry. And my job has always been to figure that out and give those patients what they need. There is no algorithm that you can use to work with here. And so I really want to emphasize what you just said, that every patient has to work uniquely. And so if those of you out there are listening and hearing this and wondering, where do you go next? Really seek the help of someone who knows what they're doing.
I couldn't agree more. I get asked that question all the time, and patients will say, well, my friend is doing XYZ treatment, why aren't you doing that treatment for me? Well, different situation, always a different situation. That has to be personalized.
So this is a bit of a 180 from where we were just focusing on, but I think it's a good switch for the last 15 minutes here. Is Laurel is curious if you have any guidelines for finding new housing or trying to prevent cross-contamination as you're going around your daily life. I know that's just very specific. I'm not sure if there's anything, your day-to-day patients might ask about that. Please address it kind of the same way if you would receive a question like that from a patient.
I want to say that, the intentions are good, right? In terms of trying to find the perfect home. But sometimes it backfires. So I'm going to say that there's no home is going to be perfect, but you have to try to eliminate as much as possible. Yes, you want it to be as perfect as possible. But I've had patients, for instance, who have had to leave a moldy home. They move into a new home that has is using low VOC material. Everything is sort of done to reduce the load of toxins, right? Everything is thought through very, very carefully. They move into the home. There's no mold in the home, it was just built. And a month into moving into the home, there's a flood. And it was remediated, but not fully. And then all of a sudden, the family's sick again. So things happen. That's really unfortunate luck. So I would just say, that's not answering the question, but I would just say that it's not easy to find new housing that's perfect. Not everyone has the financial means to put in, the special materials to reduce, VOCs and all that. I think that going into homes that you could see how you feel, you could have mold, you can have the homes tested. That's another layer of protection for some people. That's sort of answering, finding new housing that's a loaded question. I mean, it's difficult. But patients of mine who have done this, have tried as hard as they can to just ensure that the house that they're moving into has been tested, doesn't have the mycotoxins and the molds and the things that are going to make them sick, at least at that moment in time. I'll be curious to see what Dr. Nathan says about cross-contamination. That's a really, I think they mean if they're moving from a home that has mold and then moving into a home that is mold-free. Let's just say that's what they mean by cross-contamination. I go through this a lot with my patients. What do they have to get rid of? What can be cleaned? What can be cleaned of the mold, essentially, right? Can you dry clean clothes? Do you have to wash it? Do you have to wash it a certain way? And I think I've seen so many different answers all over the internet, or different ways to clean the clothes, to clean the furniture. I think it also has to be very individualized. It really depends on, there are a lot of things, right? I don't know if dry cleaning works. I don't know if you can clean an old couch, sufficiently. So those are considerations that people have to make. And, in some ways, yeah, I'd like people to just, get rid of everything that can't be cleaned properly. But again, it has to be personalized. I had a patient who had extensive mold remediation, got rid of most of her stuff, really took care to make sure that everything was taken care of properly. Except this one couch that she was in love with. And it was a new couch that she bought literally a month before the remediation, before she found the mold. Love that couch, right? So she cleaned it however she thought she cleaned it. She got rid of most of the other furniture, but that couch sat there. And every time she sat on the couch, she had the symptoms that she, correlated with mold. And every time she sat on that couch. And it took like a year for her to let that couch go. And she finally did, because she knew that it was still, contaminating her. So it's a complicated answer. I don't know if Neil wants to chime in or not.
Yeah, I agree with you. It's so complicated. For example, the case that you just talked about, it's possible that being a new couch, there could have been VOCs coming off the couch that her limbic system was reacting to, and it showed up in the same way that it would be mold. It could be really hard to tease apart. Was that mold, or was that some other, for example, fabric in fabric stores is impregnated with formaldehyde to preserve it better. And if you walk into a fabric store, there's an over the limit amount of formaldehyde you're going to be exposed to. Formaldehyde is also used as a preservative for lumber in new homes. So again, The exposure isn't always mold, but a lot of mold patients begin to blame everything on mold. Just as an aside, very, very hard question about what to take and not. I usually refer those questions to some expert remediators or IAPs that I work with. John Banta, who wrote the appendix for my book, is an excellent remediator with 30 plus years experience. Mike Schwantz, those two people are two of the best in the country. And a lot of patients have consulted with them about what to take or not take. In theory, what I've been taught is that you should be able to wash clothing repeatedly in just soap and water, and that will take mycotoxins out. Dry cleaning, not so much. Michael Gray, who was one of the first physicians to get involved with mold, once reported a case where he had somebody have a particular item of clothing that was dry cleaned 8 times and still had unacceptable amounts of mold in that piece of clothing. Now that an N of 1 does not constitute good research, but it makes you think about, well, what works or what doesn't work. Items that have surfaces that are cleanable, like metal or glass or things like that, you can almost always bring with you once you clean them and wipe them down adequately. Porous surfaces like couches, mattresses, books, papers, photographs, those are more problematic. And what we usually recommend is if you treasure them, put them in a plastic sealed container, put them in storage for a while, and there are ways of cleaning it later once you're well. When you're sick, even small amounts of exposure can make you sick. But the bottom line is very complicated. It's at least as complicated as treating mold and Lyme, and you probably need to work with a good qualified IEP to get the answers you want to your questions.
I think a good follow-up and final question to that would be testing in the home. I know we had discussed testing individuals and you had mentioned real-time labs. We did have one question about the ERMI test. Could you explain a little bit about what that is and how it can be utilized for testing your home?
Sure. Do you want to take it, Tanya, or me?
Yeah, go ahead.
Okay. So there are 3 main ways of evaluating a home for mold. Tanya mentioned air sampling. In air sampling, you basically suck the air out of the center of a room and measure the amount of spores, mold spores, in that sample. It is the gold standard of what is done in the building industry, and it is the worst way to determine whether mold is present or not, because mold spores are heavier than air. They don't float around in the center of the room. So if you were a building contractor or a landlord and you wanted to prove to the tenant that there wasn't any mold, you'll do air sampling and go, look, we sampled the room, air, it's fine. Well, that's not where the spores are. So it's often done. Patients are often told, you're fine, we measured it, not the way to go. The 2 other methods we use are mold plates, which are simply petri dishes that grow mold. You can take a petri dish with mold plate, take the top of the plate off, put it on the floor of the room for obvious reasons, and let it sit exposed to air for a couple of hours. And you simply put the top of the plate back on and you watch what grows over the next 4 or 5 days. You can send those plates to laboratories to get it analyzed. And if there are toxic mold species in any significant amount, then we have a problem. Although it is less accurate than ERMI, which I'll talk about in a second, mold plates give you an immediate sense of, yep, there's too much mold in these rooms. So you can measure every room in a house. And if all of the rooms of the house have the same mold species too high, Aspergillus or Penicillium, then we'll look at the HVAC system spewing out mold spores that are falling uniformly all over the house. More accurate is ERMI, which is a way of using a Swiffer or a vacuum and vacuuming up dust and sending that dust to the ERMI labs, of which there are several in the country. And they use PCR technology to measure 36 of the most common toxic mold species. And with that, we can get an even more accurate way of looking at what's in that home, how toxic is it. There's a method that Dr. Shoemaker developed called the Hertz-Me2 analysis, where you can take 5 of those mold species and the amount of mold, and you can literally plug it into a formula. And if the Hertz-Me2 test is over 15, got a serious problem. If it's between 11 and 15, really got to have that looked at. And below 10, you're probably okay.
Dr. Dempsey, do you have anything to add to that?
Yeah, well, what I'd add is that I think the ERMI is an important test, and I think that the mycotoxin testing of the home is equally important. You know, the mold inspectors that I often recommend, certified mold inspections, they will do mycotoxin testing. And again, I think that can be helpful to understand the situation in the house, matching it to the person. So identifying the molds, of course, are really important, but I think that added layer, because I have patients who come back with reports that say that there's very little mold, right? There's a quantification, right? Some inspectors will allow a certain amount. They'll measure the air outside very often, especially when they're doing the air testing, and they're, if there's more aspergillus outside than inside, they say, well, the house is clean because it's worse outside, right? So there are all these things that people get these answers. They're not really sure what the problem is in their home. I find sometimes adding that mycotoxin, because my understanding really is that you don't need a lot of mold to produce a lot of mycotoxin. And so it may be easier to identify the mycotoxin in some ways than actually the mold. But I think you need to do, unfortunately, a lot of these different things, because even like Lyme or vector-borne infections, we often have to use different types of testing to get our answer. We may not get it on one test. The same holds true for mold testing of the home. I think you need all these different pieces of information and put them together to get a clear picture of the home.
Okay, so we are running right up on our hour here. So I will leave this as the official last question. And this just came in from Alexis, one of our audience members. She asked, what do you think it will take for both Lyme, mold, and mycotoxin illnesses to be more widely recognized and accepted by the medical community? Very similar to what Dr. Nathan had mentioned earlier, where they're about 15 years behind. You know, it seems we're both far off. Can you explain what you feel will take us to get to a better place? And Dr. Dempsey, I'll start with you.
I'd love to answer that. I think it comes down to publishing. I think that physicians who are treating patients need to publish their findings. I think there needs to be more research in general. But the only way that the other conventional doctors, the medical communities, the CDC is going to believe what we're doing is if we have data and we have papers to support what we're doing. And that's sort of like my mission, is to publish and to get the information out there, because if it's published in a peer-reviewed journal, it will be perceived maybe better, more acceptable. And I think that maybe that will start to move the needle a little bit. I think that, we need to be, physicians who are treating patients need to be probably more vocal, and maybe lobby. I don't know, I don't get into the political stuff, but I think that we just have to publish. That's my answer. But what do you think, Neil?
So in answer to your question, what will it take? I would say about 20 years. The history of medicine and the history of all of science is that any concept which is relatively new takes years before the world, the body of medical practice accepts it. This has been happening for time immemorial. It just takes time. So the initial reaction to any new concept, I remember when Lyme was a new concept, the initial reaction was, oh, you guys are all crazy. I don't know what you're talking about. This is, you're all quacks. And we get the same response in the mold world at this particular point. Lyme is becoming more legitimized, as I said, not so much. This is the natural history. I wish it were otherwise, but this is really the way it is. I completely agree with Dr. Dempsey that we have to do more and more research. I think now that I have some time and I've left practice, I am already starting to do more research, more data collection, more publishing, because I agree with her. That is the nudge that the medical profession needs at a certain point. The public outcry coupled with the data we're collecting, the history of science is that once medicine decides to embrace it, it embraces it as if it discovered this for the first time today. And we will not be remembered, and that is perfectly okay. I don't care. But none of us who have been putting our licenses on the line and figuring this out for the last 20 years will get any credit for it, because medicine it discovered that mold and Lyme were major issues. And my goodness, we have got to take it seriously. And now the NIH has to put some of its precious research dollars into really helping us figure it out correctly. That's what's going to happen. But for those of you who are impatient, so am I. So is Dr. Dempsey. It can't happen soon enough. But having been around this block for a long time and having hit my head against that wall for a very long time, we just have to be patient and just keep plugging away.
And I'll add one more thing.
Yeah.
And that is that I wonder if the COVID pandemic and the study of the coronavirus is going to potentially help in our understanding of chronic infections and, you know, the things that we're treating. I am optimistic, actually, that some of the things they have already found supports what we are saying and seeing in Lyme disease and
right. Very good point. The research that has exploded in immunology is confirming what we've been talking about for a very long time. And maybe I'd love to think the universe will, you know, what I've said for a long time is, what do you most want to see in the mold world? What I most want to see is a change in medical consciousness. And that's what we're trying to create.
Well, I hope that Project Lyme has done a good job of supporting the change in medical consciousness, at least specifically for all the attendees and people watching live on Facebook at this moment. I want to take a quick second to thank Dr. Nathan and Dr. Dempsey for all of your great insights today. And I hope that we leave you all with a bit of hope, as Dr. Nathan mentioned earlier, that there is, you know, a path forward, and that organizations like Project Lyme and medical practitioners like these two experts that we've had with us today are working on behalf of you. So thank you both for taking the time. And as I mentioned earlier, keep an eye out for the link with this full recap sometime tomorrow from myself. Thank you both.
thank you for having me.
Thank you.